Hi, I'm Joyce Harper, and I want to welcome you to season 4 of my podcast, Why Didn't Anyone Tell Me This? Together with expert guests and those with lived experiences, we will give you some tools to empower you to live a life of good health and happiness. Today, I'm talking to my dear friend Anis. We have been friends for many years, and we are going to talk about everything you want to know about fertility treatment. Anis is the head of the Department of Obstetrics and Gynaecology at Hospital Cantonal and professor at the University of Fribourg in Switzerland. He is a fertility specialist with decades of experience, many accolades you can read in his bio. And he is currently the chair of the largest fertility society in the world, the European Society of Human Reproduction and Embryology, or ESHRE, which we will talk about throughout the podcast. So whether you're trying to get pregnant and having issues, you may be already having fertility treatment, or you may know somebody who's about to embark on fertility treatment and want to know a little bit more about it, we will go through everything from intrauterine insemination through IVF, ICSI, embryo freezing, egg and sperm donation, counseling, the stress of going through IVF, the success rates, all of that we are going to discuss in this podcast. Enjoy. Welcome, Anis.
Welcome, Joyce.
Always great to talk to you. And today we're going to talk about everything you want to know about fertility treatment. But before we do that, can you start by telling us about your career and what led you to become a doctor that works in fertility?
Thank you, Joyce, for this question. It's really a pleasure to be here. My path was not entirely linear. I started with physics because I wanted to understand how the world works and its most fundamental level. And then I moved to medicine, surgery, reproductive medicine, stem cells, and fertility. From outside, it may look like someone who could not make up his mind, but for me, there were always a logic. Understanding life first from laws of physics, then from biology of reproduction, and finally from the patient who trust us with their most intimate hopes. I came actually to Switzerland for the most scientific reason of all, love. I
Ah,
met my wife and I stayed, and more than 30 years later, I have no regrets. And actually, it's the most long follow up I have in my career. And fertility medicine become very personal to me because my wife has a stage 4 endometriosis. So she lived with this disease, with its pain and uncertainty. And after surgery, we were fortunate to conceive spontaneously twice. Our children are now adults. And when I met a woman with a severe endometriosis who want a child, I do not meet her as a stranger. I carry that experience with me. And professionally, I have the privilege of working in reproductive medicine, embryology, and stem cells, including deriving the human embryonic stem cell and first induced IPS in Switzerland. And today, as a chair of ESHRE, I see fertility medicine not only as a medical discipline, but as a deeply human mission.
yeah, thank you for sharing that very personal story. And for me as well, I started in this field in 1987 without realizing that in the late 90s, I would have a trouble getting pregnant. And I would then be the other side of the table as you've been and go through years of fertility treatment, which we're going to talk about today. So we both got the very personal story of why we're
Mm.
continuing to work in this very exciting area. Now,
Yeah.
I've just recorded a podcast with Nick Macklin, and we talked about fertility testing, and that episode's coming out just before this podcast with you. So we've talked about how we test couples, and they then will probably may end up in the fertility clinic. So let's move on to that with you. When a couple are told they may need some fertility treatment, what does that actually mean in practice?
Um, a good question. It means that we have moved from uncertainty to a clear picture when the patient really come to our clinic. Sometimes we identify a cause: ovulation problems, tubal disease, endometriosis, male factor, infertility, decrease of ovarian reserve, and sometimes we speak about unexplained infertility, which is common and certainly not hopeless. And in practice, it should mean a real conversation, not just a protocol. The couple needs to understand what we know and what we do not know, and what the realistic options are. And I want really to insist on one point: complex fertility problems should not be managed in silos. And this is really a key message. Women with endometriosis, recurrent failure, severe male factor infertility, or complex uterine disease should be discussed by a multidisciplinary team. I mean, reproductive endocrinologists, reproductive surgeon, embryologists, nurses, geneticists, psychologists, and when appropriate, patient representative. And I strongly believe the major scientific societies should issue a joint statement for this, as is in oncology. Every patient should have the same chance of pregnancy, whether she first consults a reproductive endocrinologist or a reproductive surgeon. And the patient should not depend, in a way, in her chances, depend on the first door she happens to open. And this is really a very, very important message.
Yeah, that is so important, Anis. And we're going to go through the treatments now, but obviously the treatments depend on the test. So for some tests, as you mentioned, they might have blocked fallopian tubes, they may have ovulation problems. So as we talk about the tests, let's talk about which patients are suited for this. And obviously you've talked a lot now already about endometriosis. So if we've got a couple that have come to us and they're at the beginning of this fertility treatment journey, and they're obviously, as we said, their tests will depend what sort of treatment they have. But what's one of the very basic treatments? Let's start with the intrauterine insemination. So let's talk about who that might be suitable for and what it actually involves. So tell
Uh,
us about IUI.
okay. IUI have a really a real place, but only in the right indications. And because we have really to make all the investigation properly on site, not at home,
Yes.
because this may induce stress, as we discussed, and I think both of us agree. Uh, it can be useful in mild male factor infertility, unexplained infertility, ovulation disorders, especially in young women with open tubes and acceptable sperm quality. But IUI should not become a way of losing precious time. In women approaching 38, insignificant male factor infertility, in severe endometriosis, or tubal disease, IVF or ICSI may offer a better chance. So, in my view is simple. IUI is a good treatment when it is well indicated. It is not a light IVF, and it should not be used to postpone a more effective treatment when time is biologically important. As I often say to my patients, biology is kind, but it does not always grant extensions. You see what I mean?
Yeah.
And this is very, very important in a way to go step by step and go for precise indication for IUI. And especially actually in countries where IVF is not reimbursed. And in these countries, actually, that may have happened some ironic things. People were inseminated with azoospermic samples. It's just to have the reimbursement, and this is pity for some for patients. And you see how when indications are not correct, then it's very tough and the patient may lose time.
So an azoospermic sample, let's just explain, that means that there's no sperm in the sample. So IUI, just explain to us what obviously we need sperm for that, we need open fallopian tube. So tell us for the patient, if you're going to do IUI, if the tests for the male and female are okay and they're going to do IUI, tell us what actually happens from your point of view as a clinician. How do you prepare the patients and what do they need to go through?
Okay, then first we study the cycle, the ovarian reserve. The age of patient is very important, also, as I said before. Then we have to investigate ovulation, if she ovulates spontaneously, or she had problems of ovulation, like in PCOS. Now we call it PMOS. uh, if they have the sperm is okay, we make the migration test and we see how many motile sperm we have at the end. And everything, if she patient history of the patient, if she have a kind of conization or a cervical disease, make ultrasound to be sure that the uterus is okay, no fibroids, or at least if there are fibroids, they have no impact on the cavity. And all these criteria will indicate really the good chances to success of IVF, of IUI.
And then what is it? What's actually going to happen to the patient during IUI?
Uh, okay, then there are several protocols. In a way, we can make IUI with spontaneous ovulation, but actually is not really recommended because the chances are really less than when we stimulate the ovaries. In a way, we give either kind of pills like aromatase inhibitors, and then we will follow. And once we have one, two, maximum three or follicles growing, then we um, trigger the ovulation, and 34 hours later, we prepare the sperm, select the motile ones, and then inject them inside the uterus in a way to bypass the cervix and make them nearer to the ovulated egg. And of course, for every kind of stimulation, either for IUI or for IVF, we have to uh, tell the patient that there is a risk of multiple pregnancy. And this is very, very important issue.
And what's the success rate of IUI? Just generally, or is it going to
Uh,
vary?
the success rate of IUI normally for 3 cycles is about successive cycle is 33%. It is 11 to 12% per cycle per
Right, good.
stimulation, let's say.
Yeah. So you said you've explained exactly how I do. With IUI, we're bringing the egg and the sperm closer together. So with the sperms in the womb and a few more eggs are being released. But as you said, if a woman's got blocked fallopian tubes, then that's not going to work because the egg and the sperm still need to swim, or the sperm
Mm,
swims down the fallopian tube, and the egg needs to come up the fallopian tube, and that's where they meet. So if the fallopian tube is
yeah.
blocked, then the couple have to go for IVF, full IVF. So let's move into IVF now. So with IVF, we're now going to really bring the eggs and the sperm right together because we're going to do that in the lab, and we're going to totally bypass that fallopian tube. So it's the treatment that most people have heard about. So tell us about IVF now. What's going to happen to the couple, both preparing them and when they go through the IVF cycle?
Thank you, Joyce. An IVF cycle has several steps. First, we have to stimulate the ovaries with hormone injections for around 10 to 14 days. And the aim is to obtain several mature follicles instead of one. And during this period, the monitoring by ultrasound and blood test is essential. And this is where nurses play a key role because they guide and reassure and coordinate the daily reality of treatment. And then when the size of 3 eggs at least we compare to the hormonal dosage reach 17 to 18 millimeters, then we have to trigger. And 34 hours later, we go for the egg retrieval. Usually under sedation, it is a short procedure, and most patients go home the same day. The eggs there are then fertilized in the laboratory. And this is the embryologist moment. The quality of laboratory is important, the culture conditions, and the skill of the embryology team. All of this matters enormously. And then once fertilized, the embryos are observed for several days, often until the blastocyst stage, around 5 to 6 days after fertilization. And then one embryo is transferred to the uterus, or and embryos are frozen for a later stage. Physically, IVF is usually manageable. Emotionally, it can be a roller coaster. The science is complex, but the communication must remain simple and humane. Did I
Yeah.
explain it well?
Yes, that's perfect, really perfect. So I'm so glad you brought up the emotional. So we did a survey several years ago, which we published with patients who had been through IVF and asked them why they stopped. We asked them many questions, but one was why they stopped. And emotional
Yeah.
was the top reason. It is a
Oh,
roller
this
coaster. Yeah, and I've been there. I've been on those drugs, and those drugs make you feel. Yeah, you feel. I felt crazy
yeah,
actually.
yeah.
Yeah.
Yes, and that's and that's why we have to combine not only the physical treatment but also emotional treatment. That's why in some time the patient association is really needed in a way that patient can share their experience at least to see that they are not alone and they have this same or different experience in a way to really overcome and go over this emotional, uh, we may say, crisis also, because the couples can broke during the treatment too.
I'm glad you said the word alone. Yeah, that is really how you feel as a woman. I know obviously all of this treatment involves two people, but it is a
Yeah,
very lonely journey, and it's a lonely journey. It's the woman that takes the fertility drugs. It's the woman that has the egg collected, and it's the woman who's going to get a period or get a pregnancy. So
yeah,
it is a very hard journey for both of the couple, but I think for the woman, it's really a lot of emotional pain for sure. And it's not a simple thing, is it? I think the media do present IVF as a very simple, oh, they can just have IVF. But having been through it, there's a lot of
technical.
discussion about really PTSD. Even when we have a family, I have a family from IVF, but I still,
Mm.
still feel it 20 years later. I still feel the pain that I went through those years of treatment and failure for not getting pregnant for many months, many years. It is very hard on the woman, but and the couple overall, isn't it?
Yeah, I fully agree. That's why it's not really a technical or a medical technique because we are treating human and we have to have this compassion in a way to support patient and really make them feel not feel alone and share with them their experience their feeling. Sometimes in some clinics, you have patient on the row and you don't really spend enough money. People patient, they feel really desperate in a way they don't have time to ask questions.
There are another two things I want to mention about IVF. One is it does take time, so it takes time out of your life. You said about the blood tests and the scans, and then going in for the procedure, and then the 2 week wait that we talk about while we're waiting to hear whether we get pregnant or not. So it is quite invasive to a couple's life. But I also wanted to talk about the money and the finances. But in some countries, it is funded, but in many countries the couples have to pay. So, can you tell us a bit more about how many visits would a couple need during the actual cycle to come to the clinic, and how could this impact their life?
Uh, actually, during the simulation period, patient they start to come at the when they started the simulation, they start to come at day 6, day 7 for the first checkup, and then every 2 day to the trigger. The majority of time during this period, women they came alone, unfortunately, because the majority of the clinics, if not all, they started monitoring in morning, and then the husband is in the job, and then the women or the patient comes alone waiting for the results, what the doctor will say. He will, is he willing to increase the dosage or not, or to cancel the cycle. It's really, and then which means they will make come between the stimulation and the egg collection 4, 5 times.
Yes, it's a lot of trips.
And
Yeah.
yeah,
So
it's a long trip. And actually, for the egg collection, in some clinics that I visited, the husband may enter to the room during the egg collection. In some countries, is forbidden. Then the women stays alone in any case facing the doctor. Uh, it is challenge and is emotional burden.
yeah, and in the next podcast, I'm going to talk to Becky Kearns, who has been doing a huge amount of work in the UK to support women as they going through this journey, especially how they do this during their workplace. So how they juggle this with their job, as you said, it visits every couple of days. And you obviously you're the chair at the moment of ESHRA, our biggest society in the world for fertility, but it's the European Society for Human Reproduction and Embryology, and we have our conference in London coming up with probably about 12 or 13,000 people. It's a fabulous conference. So you know what's happening worldwide. So how does the costs of this treatment vary? Because where I've been sitting, it's not something that's got cheaper over the years. They often say that when we invent new techniques, so they'll get cheaper. But I haven't seen IVF get cheaper. In the UK, it's just got more and more expensive, and the prices have really varied. So, how much might a couple pay across a few EU countries for fertility treatment?
For fertility treatment. Actually, in the website, there is a map of
Okay.
ASHRAE. There is a big map showing the countries where treatment is reimbursed, what kind of treatment is reimbursed. Because, for instance, in Switzerland, we reimburse only 3 IUI cycles, and the cycle of IVF XC may cost without PGTA around 10,000 Swiss francs, meaning 12,000 euros, which is a huge amount. Now we have also patients they go to Spain, but in any case they have to pay the travel and also the whole treatment. And the treatment in itself in Spain is 7,000 to 8,000 euros. In France, they reimburse 6 cycles of IVF. In Belgium, 3 cycles complete, treatment included. In Spain, they pay medication, but not the workup and the clinical, processes. And you see, Europe is big and heterogeneous, and that's why we can. There is no, a kind of common European legislation in a way to say we don't reach now in Europe. Population is aging. There is no country have now the renewal rate of generation, 2.2 child per woman.
Mhm.
All European countries are under this number, and they don't have a strategy to help the patients. And that's why, if you look for this disparity between national strategies, reimbursement, and also the offers like foster mothers, egg donation is not allowed in every country. And therefore, this is a kind of an engine to promote the touristic IVF, to go to travel from one country to another. And this is actually increases the burden of the emotional stress of couples and women, especially.
Yeah, yeah, I'm glad you mentioned that. So,
Yeah.
the we either call it, reproductive tourism or cross-border reproductive care, where couples go to different countries. Either the treatment's not allowed, some of these treatments will get onto illegal in some countries, and as you say, the cost varies hugely. And in the UK, it depends where you live. So some places you'll get maybe, if you're incredibly lucky, 3 cycles funded. It's quite rare, but in many places where I live, for example, you don't get any. So that's a really hard situation for couples. It's such variation, as you said, across Europe. And what about the success rate of IVF?
The success rate of IVF is really, we can say, is good, is very good. It varies between 35 to some labs claiming to 50% to 80%. There is a range. We cannot really, because it depends how you calculate. But it's really a good number and a good chance. What is very difficult is when you fail, when patients don't have really have a good, actually there is a failure of a treatment. And with honesty, the most important factor is usually the age for the success of the eggs. Egg quality declines with age, and this remains one of the central biological limits of fertility treatment. The other factors matter too: the ovarian reserve, the sperm quality, the uterine health, endometriosis, previous pregnancy, lifestyle. I know you are fighting for lifestyle. It's very important, of course, to improve, but is less considered, unfortunately, and the quality of the IVF lab. And always tell patients statistics describe groups, and you are not a group. You are two specific people with a specific history, with a specific biology. And success rate should guide decision, not define people. And we must be honest without being brutal, and hopeful without being unrealistic. And that balance is really the heart of fertility medicine.
Yeah, and you mentioned age. So the age of the woman is so important in the success of all of these treatments. And this is the
Yeah,
biology, and this is where we are stuck at the moment. So we just have to make sure people understand that in all the data I look in different countries, including the UK, the data is normally grouped for women under 35. So the success for women under 35, which is the
yeah,
highest. And then it's
yeah,
grouped normally in 2-year batches. So the UK, it's every couple of years, so 35 to 37, et cetera, et cetera. And then you can see, if you look at the data from our Human Fertilization and Embryology Authority or the data from ESHRE, then we can see that over age 35, the success rate goes down very rapidly with the age of the woman. And then in the 40s, the data normally stops at age 45. We don't normally go beyond that, but the data over 40 is very, very low. And I was discussing with Nick that on my social media, I'm seeing a lot of clinics really promoting that they can get women in their 40s pregnant. And I find this a little bit worrying because I think it can give the impression to some women, oh, I can wait. There is celebrities getting pregnant in their late 40s, and that I'm seeing all these IVF clinics promoting getting pregnant over 40. So it's okay. I can wait till I'm 42 before I start trying. So what's your view on this, Anis? Is this a problem? Should we be encouraging people to come in when they're younger, or is it safe to wait till you're 42 to start trying to have a child?
Uh, you said all, Joyce. I agree with all you said. Nature is done. We cannot really compete with nature. This is a reality. Some people will offer or sell, not offer, sell hope promoting add-ons. Huh? Some people actually go beyond the ethical limits. We know clinical, they will promote egg donation in for women or embryo donation for women aging over 50. Yeah. And then I think first we have really to make aware population that the chances are related to age. Actually, for fertility preservation, what we call it social fertility preservation, uh, many of the women who froze their eggs, actually, only 12% used their eggs to have pregnancy, meaning the rest, they don't use it because they had the pregnancy in the time between freezing and the decision to thaw them, to fertilize them, and obtain pregnancy. And and that shows that the awareness is and education is lacking in Europe and in the world. That's why we have to promote and encourage people, make them aware that, of course, the most important period is till the age of 35. And then investigation is very important. The chances are very high. And therefore, the more we wait, the more less chances we will have. And by this awareness, this education probably will solve many issues and let them know that if we have a pregnancy at the latest age, also with the pregnancy are at risk. Preeclampsia, intrauterine growth retardation, many consequences are related to age, even autism, the spectrum of autism, trisomy, and so on and so forth. And by being really aware of all this, maybe people will change their behavior. And of course, they optimize their chances to if they wish to have a child.
Yeah, so obviously something I've been very passionate about for 40 years. So I will put a link in the show notes to the resources, including information leaflets on everything we've been talking about that we made with our international reproductive health education collaboration, which is part of ESHRA as well. So I'll put a link to that. So let's move
Yeah.
on to male infertility. So if the sperm is very low, or there are other problems with maybe, as we said earlier, azoospermia, where there's no sperm in the ejaculate, there is a procedure we can use called ICSI, intracytoplasmic sperm injection, which is similar to IVF, but it's not the same. So can you tell us about ICSI? And also, if a man has problems, there are ways we can get sperm from directly from the testicles. So we'll start with ICSI, and then we'll move on to some of the procedures to try and get the sperm if it's not in the ejaculate.
Yeah. As you said, ICSI is the intracytoplasmic sperm injection. This is what it means. In a conventional IVF, eggs and sperm are placed together in the laboratory, and fertilizations occur naturally in the dish. In the ICSI, the biologist will select one sperm and inject it directly in the egg using a microscopic needle. ICSI had really transformed actually the treatment of severe male infertility. Men who a generation ago had almost no possibility of biological fatherhood can now become fathers. But ICSI is not automatically better than IVF. And this is very, very important. When sperm parameters are normal, evidence does not show that ICSI improves outcome for everyone. It adds costs, complexity, and laboratory workload. So again, the key is indication. Good medicine is not using the most sophisticated technique for every patient. Good medicine is using the right technique for the right reason. And here, embryologist training is really crucial because you can imagine a very tiny microscopic sperm that you can select and then hold the egg to inject inside. The person behind the microscope is central to the outcome. And that's why Escher's education and certification programs for embryologists and reproductive medicine professionals are so important.
Yeah, and as you said, it's the ICSI's not going to make if you're a fertile couple. Well, if you're not if you're fertile, if you're a couple where the sperm is okay, they don't need to do
Yeah.
ICSI, but it is there
No.
for male infertility, and so
Yeah.
there are these procedures as well. We can do ICSI quite easy if there's a few sperm, a low sperm count in the ejaculate. But if there's nothing there, can you tell us about the procedures
Yeah.
like TZ and things to get the sperm directly from the male reproductive system?
Mm, yeah. Then this procedure is done under also anesthesia. The man go to the OR. TZ meaning that we will go and puncture the testicular cord to have actually a sperm that is a motile but did not really go through there. We have to test first. These are what we call. If the result is negative, meaning after this puncture, we don't have any sperm there, then we will go to make a testicular biopsy in a way that we have to open the testis and then go have samples there, give them to the biologist nearby, and then he have to dissect and try to isolate some sperms or round spermatid, meaning not a mature sperm, and then try to freeze them for the ICSI procedure, because you can imagine that these sperms are not really motile, then we cannot really do IVF. And this is actually a good indication for ICSI. You see, and when the biologists say, well, we cannot find what we call it Sertoli cell syndrome only, in a way that there is only epithelium, no sperm, no round spermatid, meaning there is no production, and we cannot use own the male germ cells. Then the indication of donor sperm is legitimate.
Yeah. So for all of these well, for ICSI and IVF, if they haven't been successful, let's just first talk about the success of ICSI and the cost of ICSI. So the cost of ICSI is normally a little bit more than IVF. As you said, the embryologist has got a lot of work to do. And the success of
Yeah.
ICSI, is it you mentioned that it's not higher. So is it the same as IVF?
It's actually the same as IVF, but is lower if the indication, for instance, if because I know many labs or many centers they use ICSI systematically, and evidence base showed that if you don't have male factor, ICSI have lower results or success rate than conventional IVF. That's why indication is really very, very important. And the costs are different because since you are manipulating egg by egg, the cost of ICSI is higher. Then the question that rises, why make the patient pay more to have lower results?
Yeah. And when I was going through my treatment, the lab said, "Do you want to use ICSI?" And I was like, "No, why? Why? Why would I do it?" So I didn't use ICSI. The sperm, my partner's sperm was fine. So we never used ICSI. But the fact that I was even asked the question made me a little bit annoyed. But anyway, we'll park that.
No,
Uh,
you are
um,
right, and
yeah.
it's costs that are not needed.
No, it's not needed, it's not needed. I totally agree with you. I think we don't need it, we shouldn't do it. Now, you mentioned about freezing embryos, and my twins were born from frozen embryo transfer. So, if after IVF and ICSI, we have some embryos, you said we normally transfer 1 in most cases so that we don't have multiple pregnancies. So, those remaining embryos are very precious. So, we obviously want to keep them. So, we freeze them. The embryologist will freeze them. Can you tell us a little bit about frozen embryo transfer and the success of this treatment?
Actually, this is one of really the most important advancement in IVF. Today, we use vitrification. Vitrification is an ultra rapid freezing technique. In a way, we put the embryos in the sugar, water will go out, sugar will enter then, and then we plunge them in minus 196, and that makes a block. Comparing to slow freezing, meaning that we will freeze the water within the egg, and this may crystal, and that may harm the nuclear of the embryo and the cytoplasm. This is the main difference. And actually, with this vitrification, survival rate after thawing are very high in good laboratories, and this allow us to preserve good quality embryo and give patients more than one chance from a single egg retrieval. And it is also always safest strategy. For example, in women at risk of ovarian hyperstimulation, we can freeze all embryos and transfer them later on. In some cases, also frozen embryo transfer in a more natural environment, hormonal environment, may be preferable. We can, in a way, when we stimulate the women before egg collection. The endometrium is where the embryo will stick and grow, is exposed to many hormones and may be improper to implantation. That's why in some situations we prefer delaying the transfer and then freeze the embryo. Freezing also is central to fertility preservation for cancer patients, for women who wish or need to postpone pregnancy for a disease or social issues or family, and for some transgender patient before treatment. It has changed the way we think about time in reproductive medicine also. And it does not stop biology completely, but it gives patient options that a previous generation did not have. And that's why I said it's a good advancement and a new tool in reproductive medicine.
Yeah. Yeah, it's worked very well for me, so I'm very happy. And you've mentioned egg freezing. So I have done a podcast previously with Dr. Lucy Vanderville all about egg freezing. So if anyone wants to know more about that, they can listen to that podcast. And Anis, you mentioned ovarian hyperstimulation syndrome. Are there other risks to the couple or the woman of going through fertility treatment that we need to discuss?
Uh, Actually, the egg collection is a surgical procedure, as I said, under sedation. And then the patient have to know all the risks related to the procedure. First, the ovarian hyperstimulation, meaning that the women will collect more than 80 eggs. We have some signs during the process of stimulation by looking the level of hormones, especially the estradiol, and this is one sign in a way to delay, to ask the permission and discuss with the patient to delay the embryo transfer, because otherwise, if we transfer during the ovarian hyperstimulation. This will impair and endanger the health of the patient, and that's why they have really to make it later. There is a risk also when we go and puncture the eggs hemorrhage, and that's why patients have to know that the risk of hemorrhage, because we are going with needle to aspirate these follicles, and sometimes bleeding start. You cannot manage. You will actually notice it later on, 2 3 hours post the procedure. The risk of infection, the risk of harming nearby organs, the rectum, the big vessels, and then of course it is really rare. But then when you need to go, then you have to go in laparoscopy and of course repair the damage. And that's why a patient before going to the egg collection, they have to know all these risks.
Yeah, yeah. It's as we've said, it's not easy going through IVF, and I do get annoyed with the media when they say, "Oh, just go through IVF." It's a really complex procedure in
I
so many
agree.
ways. Yeah, and
I
Anis,
agree.
yeah, you've mentioned this, so it's not always successful. So if the cycle's not successful, obviously, if it's the first cycle, with the success rate, even in the UK for under 35s, it's about 33, 34%. So that means the majority of cycles will not be successful. But I know patients get very upset when they don't get pregnant. So if a couple have been through a few cycles, I think they have to think about this as a few cycles. It's going to improve their chances. But they've been through a few cycles and they've not been successful. What would you advise them for their next stage?
You see, sometimes I actually, as a doctor, uh, the patient may have this feeling of failure. Doctor also too, because he feel also and live this failure, and that means that first we must recognize the emotional impact, because before that both are really even to find words to discuss why it does not really work. It's very difficult. A failed IVF is not just a negative test. For many patients, it feels like a loss. And that's why I said, well, recognizing the emotional impact is really very important. And then we analyze the cycle carefully with the patient, and and we say, how did the ovaries respond? How many eggs are retrieved? Why fertilization is normal? Was fertilization is normal or not? Did embryo develop well? Was the transfer technically easy? Were there uterine or sperm factors that need reassessment? And all this, of course, making the patient participating and making this analysis transparently with them, it may help them to find the way. A failed cycle is really painful, but it can also give information. And that's why, in a way, you go step back to jump better. Sometimes the right decision is to try again with small changes. Sometimes we need surgery or genetic counseling, donor gametes, or different strategies. Sometimes we must also have the courage to discuss the limit. Don't only offer hopes, but by discussing the limits is really very important. This is where patient associations are also very important. Fertility Europe, as you know, and National Association provide a peer support that medicine alone cannot offer. And ESHRE values this collaboration because patients' well-being does not stop at the door of the clinic. And all this is really issues that have to be considered when failure happens.
And, you mentioned right at the beginning about your wife's endometriosis. So how
Yeah.
successful and what treatment would you advise for a woman that comes in with endometriosis?
And this is actually a good question because For endometriosis, uh, evidence is really, it depends if you are a surgeon or endocrinologist. Patients don't have the same chance of pregnancy. That's why I said from the beginning that we need this multidisciplinarity. Actually, the results and the facts showing that at the end of a procedure of IVF or treatment, when we compare endometriosis with no endometriosis, the success rate of the delivery live birth rate is the same. The difference is in the quality between brackets eggs, but actually they have the same live birth rate. The ovarian reserve, they need more hormones for stimulation. This is the main difference. But what is really confusing is that patient having endometriosis, half of them will have a joint disease, endometriosis with adenomyosis, that is the endometriosis of the uterus. And now we know more and more about this disease, and we know that is actually have the bigger impact than endometriosis alone on the implantation rate and the where recurrent pregnancy failure. And that's why it's really very important, this multidisciplinarity to personalize the treatment and give the patient a common view of these different specialists and she have the right to choose because these patients also they have pain and it's actually a big topic in itself, and we cannot really discuss it during this podcast. But it's really a very complicated disease because the patient have to choose between the pregnancy or the quality of life, social life, and living with this pain and all the consequences. And this balance have to be kept, and it is not really easy.
Yeah, and I have done a podcast with our friend Ertan, Sarah Dogan, so about endometriosis. So if anyone wants to listen to that, if they're suffering from endometriosis, but there is a lot we can do because I know that I know some friends that were told, "Oh, you have endometriosis, you won't ever get pregnant." So that is not true, is it?
Yeah, this is not true. I
Yeah.
agree.
Yeah. Yeah. Okay. That's good news. And actually also let's just talk about PCOS, which we now call as you said, PMOS. Again, I've heard people with this disorder being told, "Oh, you won't get pregnant or you won't get pregnant naturally." So what's the outlook for women with PMOS?
It is not true actually that they don't they because they may ovulate. I have many patients. It's not rule, but many patients they don't have their menses and they come and they are pregnant because they ovulate once everywhere and it happens that they get pregnant. And actually, it depends on the symptoms we have. That's why we have really to dissociate two issues: symptoms that the patient have with the hair being in really disgraceful places. And there are women, they want their regular menses. Then we have specific treatment for that. For conception is different because the likelihood sometimes there are women they don't have actually regular cycles. They may ovulate 3 or 4 times a year, and therefore they need the help in a way to stimulate the egg to obtain the pregnancy in a way to really synchronize everything, which means that their chances are the same. Of course, if they would go to IVF, they have a higher risk to ovarian hyperstimulation because they have many follicles, and then the answer is you can inexpectable in a way. We don't know how they react, and that's why we have to be careful when we stimulate these patients.
And let's go back to the donor eggs and sperm. So if a couple can't get pregnant with their own eggs, you've mentioned
Yeah.
donor sperm already. So donor eggs and sperm is absolutely a possibility. Tell us a little bit about that and the success rate of using these treatments.
Donor sperm can be used in cases of severe male infertility, or of- for in some countries, like not in Switzerland, for a single women. The law changed very recently, and for a single women or same-sex female couples, depending on the legal framework of each country. Donor eggs are often used when a woman's own egg cannot offer a realistic chance. For example, in premature ovarian insufficiency, or after repeated IVF failure, or at advanced reproductive age. These are some examples of conditions where donor egg is indicated. Medically, donor egg treatment can be very effective because egg age is a major determinant of success. And normally, the centers who practice this the kind of treatment or offer, they collect eggs in women they have normally proved to have live births. And of course, they are tested and they are less than 35. But this is not only a technical decision, it involves identity, genetics, family story, laws, ethics, and psychology. And I always insist on counseling. It's really very important. Patients need time to reflect. The future of the child also has a story, and that story should be built with honesty and care. And parenthood is not reduced to DNA. Pregnancy, birth, love, daycare, emotional presence are also biology. And there are also family. And this is to be considered. Actually, the success rate is good in these selected groups. It make them reach the normal rate of IVF and XE around 34 to 40% of success rate.
Yeah, and you mentioned counselling there. So most fertility clinics for all patients, they offer counselling. As we've said, this can be a very difficult journey. So counselling is there in I believe all fertility clinics for any couple. Obviously those going through egg and sperm donation, but for anyone, and it should be something that's really embraced. It's a difficult
Yeah.
journey. So is counselling a good thing?
No, counseling is very important. However, for some countries, when they go for egg or IVF donation, they will do it in other countries.
Yeah.
And I believe that this part is really missing in a way, all this follow up, because counseling in choosing the correct donor and also psychological counseling is very important. What to say to the child, the born child, because it will not stop in the procedure. And the majority of these patients are lost because they are seeking how to someone advise them and counsel them how to say, how to grow with this child, how to exchange, because it will not stop in the delivery. It's a long process too. And that's why it's really very important counseling from the beginning, and the follow up of the counseling is very
Yeah.
important.
And also after a failed cycle, when that period comes and there's no pregnancy, this is a really important part of time when a couple
Yeah.
might want to seek some counseling to just discuss their feelings and their sense you said sense of loss, at not achieving a pregnancy. Um, Anis, you
And
have mentioned lifestyle. We're almost at the end, but let's just talk. I think lifestyle, obviously, I think that's really important. What advice do you give a couple when they're coming to you and they're at the beginning of their journey regarding their lifestyle?
Um, Probably I will say a joke, but uh, do that what I say, but not do what I'm doing. You
We won't tell people
understand me?
what you
I,
do.
I will give really give simple evidence-based advice because patient actually, you know, we have to give them really effective advices. First, do not smoke. Smoking clearly harms fertility and accelerate ovarian aging. Aim for a healthy weight because both obesity and being underweight can affect ovulation, implantation, and pregnancy outcome. Limit alcohol, sleep well, exercise moderately, take folic acid when trying to conceive. And for men, lifestyles matter too. Smoking, obesity, alcohol, anabolic steroids, heat exposure, and some medications can affect sperm quality. But I'm careful not to recreate a guilt. And this is really very important because when you start to talk about weight, behavior, people they may have a guilty, they feel guilty. And when there is a failure in the treatment, it really impairs actually this feeling. Lifestyle can support fertility, but not all infertility is caused by lifestyle. And this is very important. Women with severe endometriosis or low ovarian reserve should not be told simply to relax and eat better. That is not science and it is not kind. My message is really improve what you can, but do not blame yourself for what you cannot control.
Yeah. You mentioned weight loss. So actually let's just briefly talk about these weight loss injections. We're seeing now a lot of women getting pregnant. What's your view about what's happening there?
You know, going through kind treatment is really personal. You know what? You have to we distinguish between that between people that have a disease, obesity disease, and then they need within their treatment these kind of injection. And others, they have moderate obesity, but they don't feel comfortable with this. And then they started in a way the doctor they said, well, you have to decrease your weight and then try to and inject this. You will lose weight. Probably you will ovulate spontaneously, and it will improve. And that's why it's very important that the patient don't feel guilty, and the doctor is not his work to make guilty the patient. He have to help them. If a doctor sees the patient taking these injections, he have really to follow her, to support her in her process. And actually, as you said, there are results coming showing that people with the Rigovir and other treatments, they have spontaneous ovulation and good live birth rates. However, there is a lack now of evidence in combining both treatment, IVF or ovarian stimulation, plus the injections. But
Yeah.
probably evidence is coming.
Yeah. Yeah. We're working on it. We'll hopefully see some things hear some things at our annual conference in July. Um, Also, I wanted to talk about social media. So I recently did a post when I found out this terrible myth that eating McDonald's fries will improve your chance of getting a baby if you eat them on the day of your transfer. And I was horrified when I heard this total misconception. And I did a couple of videos on social media, and then I got bombarded by very angry couples saying, "How dare I tell them not to eat McDonald's fries?" So it's a crazy world out there with social media. So as far as social media goes and fertility treatments, do you feel it's a problem, or are we getting the correct information from the influencers?
You mean the most common misconceptions, and the social media made
Yeah,
it worse. This is what. Uh,
yeah,
well, the biggest misconception is that IVF always works. This is,
yeah,
you said it.
yeah,
It's not. It's really a light procedure. Go for it, but it does not. It is really. It is a powerful treatment, but not a magic. Another misconception is that fertility can always be postponed, and society has changed faster than ovarian biology. The third misconception is that uh, every failure means that someone missed something.
uh,
Sometimes the embryo simply did not have the capacity to continue. And social media has, however, also positive aspects. It can reduce isolation, create community, but it also amplifies the exceptional stories, miracle cures, and unrealistic expectations. And that is why public education is really uh, uh, very important. Actually, support the education of professionals, but also the information of lay people through such IREC that you are the chair, and through collaboration with patient organizations, that's Fertility Europe. And we need to communicate evidence in a way that is clear, honest, and accessible, not to remove hope, but to protect hope from misinformation. And you see, they have good aspect in a way to avoid isolation, but you have also what we can say fake news.
yeah. Yeah. But for me, the one of the biggest, misconceptions I see a lot is about IVF add-ons, and I very briefly
Ah,
discussed them with Nick, and we haven't discussed them yet, but I think that's a good place to finish our conversation. So, it's something I've been very passionate about for many years. I was involved with the HFEA, that govern fertility treatment in the UK. I was involved with making a traffic light system to help patients understand this. And I was part of the ESHRA group that wrote about IVF add-ons, and we wrote about 42 of these IVF add-ons. So these are treatments and tests that are suggested that they're going to improve your chance of getting pregnant with this fertility treatment, and there's many of them there. They can have a look at the ESHRA document, which lists these. So I think they're all made with good meaning. They're all made and designed to try and improve. But in my view, the evidence, and we need to look at scientific evidence, unfortunately, in almost every case, doesn't actually show that they deliver what they say they're going to deliver. So Anis, what's your view about these IVF add-ons?
I will be really direct. Many IVF add-ons are offered to patients, like endometrial scratching, immune treatment, special tests, supplements, laboratory technique. Some may be useful in selected cases, but many have limited evidence of routine use. The problem is not really the innovation. We need innovation. I think we agree, both of us. The problem is selling hope with strong evidence. Before proposing an add on, we should ask, is there good evidence? Is it safe? Is it useful for this particular patient? And is the patient receiving transparent information? Actually, your work with AFEA and the work of Ashley is trying to answer to these main questions in a way to give a recommendation. Patient infertility care are vulnerable because they are hoping for something deeply important. That vulnerability must never be exploited, and such scientific societies like ASHE have or HFEA regulatories have a responsibility to produce independent guidelines, evaluate evidence, and help patients distinguish between medicine, innovation, and marketing.
Huh.
And hope should be really part of care. It should not be an item on an invoice. This is and what we notice is the majority are going to the latter one than the first part of my sentence.
Yeah, when I was going through IVF, I was offered add-ons. I didn't take the add-ons. I didn't take supplements. I've got some research coming out. We've done a few research projects now about fertility supplements. I didn't take any of them. I don't think anything's changed. I took folic acid, obviously, which is very important, but I didn't take anything else. So it's a minefield. As you said, we are vulnerable when we are here. If someone, even now on social media, an influencer says, "Oh, this worked for me," then it gets in people's heads and they think, "Okay, I must try this. I must try that. I must try something else." And it can be overwhelming. But I think keep it very simple and be aware that a lot of this, as you said, is absolutely marketing. Now, we've
Yeah.
recorded this before our big annual conference, our ESHRA conference that's going to be in London. Very exciting. Do you think there's anything on the horizon, any new technology that's going to really change fertility treatment?
There are several promising areas, but we must be precise and cautious. Artificial intelligence. I know many people are working in that, and it may help embryo assessment, improve laboratory for workflow. Genetics is improving our understanding of embryo reproductive disease, but also you have to be framed. This is your field where your expertise is, Joyce. Fertility preservation is also advancing, especially for ovarian tissue transplantation after cancer treatment. Stem cell research and in vitro gametogenesis is fascinating, but for human clinical use, they remain future possibility, not routine treatment today. In endometriosis, we are learning more about inflammation, the immune environment, the microbiome, the endometrial receptivity, and this may open new therapeutic strategies. And I believe one biggest revolution may not be technological, it may be organizational. We need really, I come to this because we are preparing a statement for that. Because we have, if the scientific societies really don't write this statement, it will not really respect it and put in place. We need the multidisciplinarity boards for complex fertility patients. Reproductive endocrinologists, all specialists of our field have to sit and work together. And this is especially important for really many diseases of our specialties: endometriosis, recurrent implantation failure, severe male infertility, complex and surgical. And I would like to see a joint statement really of all major scientific societies saying clear every patient deserves the same chance, regardless of which specialist she sees first. The question should not be who owns the patient. The question should be what is the best pathway of this patient. And these are probably the things that are going to be discussed during the annual meeting.
Yeah, I'm really going to be looking forward to that. It's going to be a really powerful statement that's going to be produced. And actually, another burning question is if the couple are now deciding to go through fertility treatment, they sit there and they look at the fertility clinic website. So I know that they do this. They'll sit there and they'll look at different clinics within their area. And I've done a lot of research looking at the clinic websites. And you will see clinics that have all this new technology, and you'll think, oh, that's a great clinic. They're offering this egg imaging and AI for embryos and blah, 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 blah. But in real terms, as you've said, and I've said, there's no evidence that these will help, but they're great marketing tools. So it looks great if you see this website that has all this new technology. You think it must be a fabulous clinic. But my view would be be very cautious about that. Be very cautious about, as you said, they can over amplify their data. In the UK, we do have a finder clinic from the HFEA, and it will, on their website, I think it still does, tells you the success of the clinic from the data that they submit to the HFEA. So, any advice on how a couple should decide which clinic to go to?
Well, actually, I would say that probably the scientific societies, probably all regulatory country regulatory institutions have really first to protect the patient in a way to state as HFEA said with the lights. This is really very important, and actually they have to stop also some clinics of advertising things
Yeah.
that are really not true in a way to protect the patients also from a decision. And of course, if these laboratory or clinics they don't really answer or in a way adhere to this regulation, then probably stopping these clinics is and but it needs courage in a way to go and stop these clinics advertising things that are not really evidence based. And we have to, and also there is one step it's very important, and actually hierarch and patient association have to do is awareness. I know, for instance, for some endometriosis patient association, they are making and ranking clinics according to their results because they have to be certified centers. They have to publish their results. They go to patient association and then they rank. And of course, in the IVF field, this is not will be welcomed because
Mhm.
there are big financial issues there. For endometriosis, if you are competent in surgery enough, but then if you are not, of course, you will not go like cancer centers, you know. It is specific center with specific competency where you have. But for IVF, since the media, social media, society say, well, it is not really difficult. It is an easy procedure. Then people they may say, well, it's easy, let's go. But when they go to this process, they see the complexity, which is what is evidence, what is add-ons, what is marketing. And it's really difficult to advise patients because they are free. They go by their own. They have easily access to information. And I think it is better that they go back and cross-check. Don't choose the first choice. Go and ask other clinics or other experts to see if really it is the same. They would have the same answer. If it is not, then they just go for one that is really in their country.
Yeah, yeah, I think that's excellent advice. So I hope anyone listening to this who's trying to conceive, I hope we've provided some really useful information, and I'll put some links in the show notes to some of the websites we've talked about, such as our International Reproductive Health Education and also ESHRA, where there's a lot of information for patients trying to get pregnant, and Fertility Europe. And the HFEA. I'll put those in the show notes. But Anis, I finish my podcast always with brightening things up, asking some questions totally unrelated. Now, I know that you're a very good singer because I've heard you sing several times. You're a fabulous singer. But I wanted to ask you what makes you happy and where is your happy place? It might be singing, but it might not be. So, what makes you happy?
Ah, singing, as you said,
I thought you said that.
dancing, you know
Yes.
that you like more of us dancing. Uh, my family, my children, my patients, when they come back with a baby, sometimes they send a picture years later, and the child is going to school. My happy place is the sea. I like swimming, but not in cold water as you're doing. Uh, I love the moment when the sky and the water seems to merge and become one. Uh, You no longer know where one ends and the other begins, and it gives me perspective. Maybe it is also the physicist in me, or maybe it's just a man who occasionally need to feel very small in front of something very vast. And yes, after difficult weeks, the sea is sometimes cheaper than therapy, and although unfortunately not reimbursed by insurances.
I think the sea is the best therapy, definitely, whether it's
Yes,
warm or
it
cold. And, Anis, I have one more question. So, this is sometimes a
is.
tricky one for people, but what advice would you give your younger self? It may be specifically to you, or it may be to younger people who are now coming up through life. What advice would you give to your younger self?
Mm, I would say do not be afraid to live between disciplines. You know, some people thought when I started my career, I was too scientific to be a surgeon. Others thought that I was too surgical to be an academic. But the most interesting work often happens at the borders between surgery and biology, between laboratory and clinic, between evidence and hope. And I would tell my younger self, take care of your team. Embryologist who stays late, the nurse who notices the patient is not coping, the biologist who checks one more detail, the colleague who changes your plan, and they are all part of the outcome. And finally, I will say stay humble. Science moves fast, but patients remember how you made them feel. Clinical excellence is never a solo performance, it's always an ensemble. And these are the advices I would give to a younger self.
They are very beautiful words to finish this very informative podcast. Alice, thank you so much. I'm looking forward to seeing you in a few weeks. And thank you for being on the podcast.
Next week,
Yes, it's
huh?
coming.
Who will be next week?
I will see you then. Thank
I'm
you.
really happy to see you then and to dance together.